So thank you for organizing this, and thanks for coming. I'm delighted to talk to you about these things. I was asked to do this ounce of prevention talk, and I thought what would be the most appropriate thing to discuss about Parkinson's, since we can't really prevent it. Are there ways to prevent the disease from getting worse or from symptoms from being unnecessarily cumbersome? And there are a few things that come up pretty frequently, and I thought we should just pare it down to a few of them here. So I have a little outline about what I'm going to talk about here. I'm going to give a quick plug for our newsletter, a brief description of Parkinson's disease, and talk about the effects of exercise, whether or not you should adjust your own medications, and get into supplements. So this is our landing page for the Maine PD News. It's a nonprofit quarterly newsletter for the state of Maine. If you just type into your URL, www.mainepdnews.org. We have two editions. The third edition's coming on this month. I have people from around the state contributing. Dr. Pilopoulos wrote an article last month, and Dr. Kleinman is in this month. Pilopoulos is in Bangor, Kleinman's down in Portland. Various things. I've had a lot of help from speech-language pathology, like Yanja here wrote a nice article, and from occupational therapy, physical therapy, and other people involved in the care of Parkinson's patients. So please feel free to take a look at that. So let's get into a brief description of what Parkinson's disease is so that we're all on the same page. Just a couple of slides. As you all probably know, Parkinson's is a progressive neurologic disease, and multiple systems are affected. The early warning signs are the loss of sense of smell, which can occur years and years, sometimes decades before the onset of motor symptoms. Constipation, at least 40% of people have constipation in the 7 years leading up to the motor symptoms. And REM sleep behavior disorder, which is acting out dreams in the night, calling out, thrashing around, waking up twisted in bedclothes. A lot of people have that. If you have all three of those, it's very likely that Parkinson's disease is in the future. Once a person has lost about 60 to 70% of dopamine production in the brain on one side of the brain, they begin to manifest the motor symptoms. And the three cardinal motor symptoms are tremor, stiffness, and slowness. The gait changes come later. Motor symptoms are mostly due to that deficiency of dopamine. Dopamine is a neurotransmitter. This is a chemical the brain makes for one neuron to communicate with another. Dopamine can be replaced by medications. The most common is Sinemet, carbidopa, levodopa. As time goes by with the disease, patients do experience problems with gait changes. This is walking, balance, falls. Memory can be a problem. Sleep disruption, apathy, and depression are all very late findings for most people. So what can we do? One point that comes up a lot is that exercise is very helpful. I think of exercise as medicine. For 30 years, there has been a lot of data, a lot of investigation into what exercise is doing in Parkinson's disease. And we found with lab animals and with people that exercise increases dopamine in the brain, exercise increases function, exercise improves movement, exercise can improve balance. And there are a multitude of studies. I just picked a few to talk about here. But the thing that you should take home from this is a lot of people refer to muscle memory. There is no memory in muscles, of course. They don't remember anything. But your brain does. And when you form new pathways in your brain, this is called neuroplasticity. So those new connections, new networks of neurons are these plastic connections. And when you practiced over and over as a child to learn to play the piano or the cello or something, and eventually you got it and it became natural, or you learned to ride a bike, or you learned how to do the tango, you eventually had formed some new network in the brain. You were plastic, and you learned that thing. And the rest of your life, you have the ability to be plastic. You can do this. And the idea with neuroplasticity is, of course, creating new connections, trying to go around the problem, trying to improve the function. And sometimes exercise can actually do this other thing. It can increase dopamine in the brain and other neurotransmitters. So let's look at one exercise study. I love this concept of forced exercise because it doesn't sound gentle at all, but it's actually very helpful, and it's very interesting. So this was a small study back in 2009. They took 10 people with mild to moderate Parkinson's disease, and they divided them into two groups. And the study went on for only 8 weeks. They had one group did the VE group, means volitional exercise, so they got to pick how fast they were pedaling a stationary bike. And they had to hit a target heart rate, so they worked with a trainer. They had to figure out what is your target heart rate and how should you get there, but they let the patient pedal at the rate they wanted to as long as they hit the appropriate rate. The forced exercise group worked with the trainer. They figured out what their comfortable level was, and then they made them learn to pedal 30% faster. And by learn to pedal, I mean they had to work their way up to it. And they pedaled at a 30% greater rate. Both groups reached their aerobic heart targets. And what happened was that aerobic fitness improved for both groups. In other words, they were better at aerobics. They could go longer. They didn't run out of breath as fast. But in the volitional exercise group, they did not improve their motor function. Their Parkinson's, Unified Parkinson's Disease Rating Scale is what Unified, or UPDRS stands for. It's that thing I do in the clinic and any movement disorder doctor does, where we have you hold out your hands and touch your nose and touch my finger and all this stuff. And we're actually scoring you on that thing. There's a range of points. You can score a perfect score, which is 0, or you can score the worst score imaginable, 108 points. Nobody ever hits 108 points. But the forced exercise group improved their scores by 35%, which is remarkable. That's about what we get when I give people carbidopa, levodopa. Dexterity improved, and at 8 weeks, they asked people to stop exercising, to agree not to exercise, and then brought them back in a month later and tested them, and the improvements were still there, only in the forced exercise group. So bringing your heart rate up, exercising a little bit harder, a little bit faster than you had intended to. That's my phone. Isn't that cool? Silence your phones, please. Good grief, stop. All right, let me silence my phone. All right. So bringing your heart rate up is the idea, but it has to be done with care. You have to know that you can do this, and you need clearance from a doctor to exercise at that level if you're beyond a certain age. Another study looked at high-cadence cycling. So that's the idea, pedal faster. This study, they had this thing called the motored cycle, aka the motorized cycle. And the idea is that the motor will turn the pedals. They took two groups. One group of 24 people pedaled at a rate of 75 to 85 times per minute for 30 minutes. And another group took this more comfortable level. What they did was they figured out where they felt comfortable but could maintain a pretty good heart rate for 30 minutes. And again, they looked at their Unified Parkinson's Rating Scale and this thing called the timed up and go. A lot of physical therapists use that. And they measured them after 3 sessions, and what they found was that in the dynamic group, the group pedaling faster, they improved their motor scores by about 14%. They improved their ability to stand up and walk by about 17%, versus the static group, the group that didn't push as hard, only improved by about 1% of the motor score and about 8% of their ability to stand up. So this is another topic that has come up a lot lately, boxing training. This is really popular these days, and there have been all kinds of news shows about this. I saw it on a morning show. Leslie Stahl did a show with her husband. This comes out of a physical therapy group. They started with a small study with only 6 patients. And over the course of 12 weeks, they did up to 36 90-minute sessions with these guys. And they showed that doing boxing drills, stretching, strengthening, and endurance actually was helpful. They tested them at the beginning, 12th week, 24th week, 36th week. Nobody punched anybody, by the way, and nobody got punched. But improvements were seen in at least 5 out of 12 outcome measures. In other words, they were checking a whole lot of things to see what improves and what doesn't. And this was a very small study, not really powered to generalize about the population, but just whether or not this is a feasible thing and whether or not it looks helpful. They did show improvements, and they were fairly modest. Another study, same group, they looked at 31 patients and randomly assigned them to either boxing training or more of a traditional exercise. And the difference between the two really comes down to the types of exercises, and the traditional group did these very focused balance exercises. And they were tested before and after. And in the traditional exercise group, they scored significantly greater in something they called balance confidence. How comfortable do you feel about your balance? And in the boxing group, there were significant improvements in gait, in the velocity of walking, endurance over time. And both groups showed improvements with actual balance, not just balance confidence, but the actual balance, mobility, and even quality of life. And so there is a lot of data there. There are multiple studies looking at all kinds of exercise, and the key with all of them is that you're working out past a certain comfort level, you're pushing into a new comfort level, you're making your heart beat a little bit faster. There are studies showing that working on core strengthening is good, studies showing that yoga can be very helpful for balance, that Tai Chi can be very helpful. There are even studies looking at Argentine tango. It can be really useful, but if you look closely at how they're doing this, it's still a pretty aerobic exercise. University of Washington did one several years ago on the foxtrot that was pretty interesting. And they had their own formal Parkinson's exercise program, and they pitted the foxtrot versus their exercise program, and I thought that the idea was they were going to show, look, ours is better, but the foxtrot won. So we'll move on to point 2. Exercise is good. Point number 2, adjusting your medications may take you places you don't want to go. So I see a lot of Parkinson's patients. I did a little inquiry in my computer system recently and realized I actively have almost 700 Parkinson's patients, and I have dozens of the other ones that look sort of like Parkinson's, like PSP, MSA, CBD, et cetera. And I'm happy to see all of you, but this happens every day, this thing I'm talking about here, adjusting your own medications. It is a complex situation, the balance of dopamine in the brain and the effects of what that dopamine are. And it always amazes me when people come in and say, oh, I changed it. Because I think, wow, it took me a really long time to figure out how to do that. But at any rate, let me get into why. So Parkinson's meds primarily replace dopamine, and all meds have potential side effects. So taking a more is better approach may not necessarily be the right idea. With carbidopa, levodopa, Sinemet, for example, the common side effects are things like lightheadedness, nausea, confusion, worsening constipation, impulsivity, even hallucinations are reported sometimes, especially if a person is predisposed to hallucinations. So you have to be careful. It's not a casual thing to just double up the dose or throw in a few extra pills. And there's this other phenomenon of too much too soon. We've known since 1970 or so that taking too much levodopa is probably a bad idea. If you put people on enormous doses, they may feel wonderful for a year or two, but after a year or two, not so great. Dyskinesias, these involuntary kind of twisting, turning movements, sudden failures of medications. You take a dose and it's working, and then all of a sudden, way before it's supposed to stop working, it stops. Or just random failure of medication altogether. I took a dose and nothing happened. And that sort of thing can happen if you take too much too soon. In fact, this has been shown in multiple studies. I didn't want to get bogged down into all the details of these, but the big L-DOPA trial in the 1990s showed this. There have been other trials in between. 2014, there was a trial in the British journal Brain that I referenced at the bottom of this slide, comparing, interestingly, affluent Italians versus sub-Saharan Africans. And the trick was that some of the affluent Italians had access to whatever they wanted and were taking fairly high doses of levodopa early in their disease. And they compared these against Africans who were not, in fact, had never been exposed to medications. And at 10 years, what they found was there's really no difference in the progression of disease unless you were one of those people who took too much levodopa in the first few years of your disease. And then all of those things I mentioned happened much earlier. But we've seen that again and again. Dopamine agonists, they're like synthetic dopamine. They also have potential side effects. confusion, hallucinations, foot swelling, sleepiness, sleep attack. Sleep attack is when you're just sitting there and you are suddenly asleep and didn't realize it was coming. That's really bad if you're behind the wheel. And that does happen occasionally. Usually only happens at very high doses. And again, sometimes people feel really good on these drugs and they think, well, today, double. Not a good idea. And then at the bottom I listed impulse control disorder. This is when someone knows it's a bad idea to gamble or something, but they just keep gambling with this impulsive behavior, like gambling past their means, or spending, or traveling, or sometimes it's libido. There can be inappropriate sort of behaviors, and we don't have to go into all the detail about those, but what's happening is the part of the brain that is involved in that sort of reward system that makes you do risky behaviors, like jumping your motorcycle over the fountain at Caesar Palace in Las Vegas, which was really cool when Evel Knievel did it. When people decide they want to do that sort of risky behavior, they're stimulating a part of the brain that is stimulated by dopamine. And so if you really ramp up the dopamine stimulation, you might start thinking that's a good idea too. What about underdosing? People frequently tell me, I'm just not a pill person, and so I cut back on that. And frequently they'll say, I tried it for a few days, up or down or whatever, and nothing happened. And there are two things there. Sometimes it's not so obvious what's going on. You might get a holiday for a day or two with no side effects and feel fine. Like you've got so much momentum that everything's fine. But if you wait about a month, there's this problem called the steady state. So if you stop taking your drugs the right way after about a month, you have a new steady state. And that is when you start to notice that, symptoms are worse. And abruptly stopping drugs. This can actually be dangerous. And I always warn people taking, especially levodopa, but any of these drugs, don't just abruptly stop them. There are rare, admittedly very rare case reports, but there are case reports of people having life-threatening reactions to stopping these drugs abruptly. And the syndrome, neuroleptic-like malignant syndrome, all of those words together sound bad, right? Except for maybe like, but it's bad. It's worse than it sounds. People die from it sometimes. So abruptly stopping drugs is a bad idea. I always tell people, if you're going in the hospital for surgery or for any reason, have them call me, or I'll talk to them or whatever, because it's not a great idea to just abruptly stop. And lastly, in this category, a lot of patients ask me about plants, what plants make medications. Close to half of the drugs we use, I've read, are derived from plants. If you can make aspirin from willow bark and warfarin from sweet clover, imagine. There are lots of things out there that we derive drugs from. But this is a list of FDA-approved drugs, drugs that have been tested and regulated, and we hope we have good safety data on. And these drugs are just as dangerous as they are helpful. And the same is true for other types of things people take. Which brings me to this point, point number 3. Supplements may not be as safe as you think. So nationally, Gallup polls and consumer reports and all kinds of different agencies, I think the Institute on Medicine said the same thing, that about half of Americans take supplements. But in my clinic and in academic centers for movement disorder patients, about 75% do. And the same is true, incidentally, among cancer patients. I think when people have a disease for which there is no cure, they start thinking, well, there's got to be something that will help, and maybe there's some help in vitamins and so forth. So let's explore that a little bit. Vitamins are by definition required for your health, but most of us who don't have a deficiency don't need them. If you're a pregnant woman, maybe you need folate, for example, but most of us don't need vitamins unless there is some documented deficiency. And there have been multiple studies showing that people without a deficiency don't get any benefit from taking vitamins. In fact, in 2013 in Annals of Internal Medicine, there was this editorial on the heels of 3 really large studies about vitamins. And look at the title, "Enough is Enough. Stop wasting your money on vitamin and mineral supplements." Why would they say that? And what is this quote at the top? The U.S. supplement industry continues to grow, reaching $28 billion in annual sales in 2010. According to Consumer Reports, this year that number is $40 billion. So this was a meta-analysis. This is when you look at the data from a whole bunch of studies, and they had criteria. They didn't just look at any studies. They looked at well-designed, at least fair studies where they thought the capture of data was good, and they're all in peer-reviewed, published journals, medical journals. So they looked at a total of 27 studies involving about 400,000 patients, actually more than 400,000. And what they concluded was there was no clear evidence of a beneficial effect of supplements on all-cause mortality. That's all causes of death. There was no benefit for all causes of death. Cardiovascular disease, heart attacks and so forth, or cancer with taking vitamins in people who have no known deficiency. So just taking a preventive just in case doesn't seem to help there, does it? This was the Physician's Health Study. Almost 6,000 men were divided to a placebo group and to a multivitamin group. They were all doctors. They were all 65 and older. They were all followed for 12 years. There were no differences between the multivitamin group and the placebo groups in terms of cognitive performance. Does it help you mentally, or does it help you with preventing cognitive decline? Are you going to have dementia or not? It does not matter in this study. And there, as far as I know, have been no studies showing that vitamins can slow down the progression into dementia. And in fact, they took another look at this and found 12 trials that evaluated people who already either have mild cognitive impairment, and this is important because a lot of people with Parkinson's have mild cognitive impairment, or do they have mild to moderate dementia, and somewhere on order of 30 to 40% of people with Parkinson's will develop dementia, unfortunately. 12 different trials evaluated multivitamins, B vitamins, vitamin E, vitamin C, omega-3 fatty acids. None of the supplements improved cognitive function. And to the best of my knowledge, neither does CoQ10. It wasn't included in this meta-analysis, but there are multiple studies looking at whether or not CoQ10 prevents Alzheimer's, prevents dementia. And in animals, there may be some data to help sort that out, but in people, it just hasn't borne out. This one, a high-dose 28-component multivitamin. So they grabbed as much stuff as they could, and the most potent vitamin possible, and divided up 1,700 men and women who had a history of heart attack, followed them for 4.5 years, and showed no significant decrease in the incidence of cardiovascular disease. So earlier I said it is complicated. It is, because in Parkinson's disease there are at least 3 vitamins we know of that may be deficient by virtue of the fact that the person has Parkinson's or perhaps related to the medications they're taking. But you do not want to replace vitamins blindly. Vitamin B6 was found in trials in Europe to be low in people with the dopamine pump. So they're getting a continuous infusion of dopamine. And several of them developed these terrible neuropathies. Well, they ranged from a mild sensory neuropathy to a severe neuropathy. And in many cases, they found that they had a vitamin B6 deficiency, and that was probably the culprit. The problem was they didn't screen before starting the pump. And so they looked at these epidemiology studies and said, what about people who take high doses of levodopa? They've taken pills for years. What's the incidence of B6 among them versus people who don't? And it's actually higher. And so there's a lot of indirect evidence that B6 may be lowered by taking large doses of levodopa. And the idea is check the level. Don't just blindly replace it, especially with the situation we're in our country. And I'll get into that here in just a second. The U.S. recommended daily allowance is that if you're a man over 50, take 1.7 milligrams. If you're a woman over 50, take 1.5 milligrams of B6 a day. If you need it, you're probably getting it from food. But if you walk into the grocery store, you can easily buy a 100 milligram tablet, and it says right there on the bottle, take daily. What's wrong with that? Aren't vitamins good for you? Isn't more better? Well, vitamin B6 can become quite toxic in your system. That's been well documented for decades. The first article about that, about B6 causing neuropathy, was in 1983, and there have been multiple since. Just this past summer, there were 2 major academic centers of neuropathy in New York that looked at all causes of neuropathy in their clinic and found that in one case, in just a sample over the past year, and in another case over the past 12 years, if you add up all the people who had vitamin deficiency as a cause of neuropathy, which is the thing that we all read in textbook as one of the major causes, if you add those up, it's still not even half the size of the people who have neuropathy because they're taking too much B6. In fact, in the study over the last year, it was 3 times as high, the people taking too much B6. I'm glad I silenced my phone. It's going off again. Wow. So what about vitamin D? Vitamin D is really an interesting molecule. It's sort of a master hormone. It does more than protect your bones. It's involved in your brain, and it's involved in how dopamine functions. There are vitamin D receptors in the basal ganglia. And there are interesting studies looking at normalization of vitamin D. Does that improve motor function? I talked about this last year at the Parkinson's Awareness Day in April down in Portland. And I went over some data about this. And then over the next 6 months, I had a couple dozen people come in taking enormous doses of vitamin D just to keep their vitamin D level high. And that was not my intention at all. So let me just say now, as I've said to each of them, again, check a level with me or your doctor or whomever. Because acute vitamin D toxicity causes confusion, it can cause excess urination, vomiting, muscle weakness, all kinds of problems. And if you do this chronically, kidney stones, bone demineralization, and pain. I've seen people develop a chronic pain syndrome from taking enormous doses of vitamin D. It's not a safe thing to do. But again, you can walk into the grocery store and buy enormous doses because the FDA doesn't really regulate vitamins. They're considered dietary supplements, just like all these herbals and stuff that we can buy. They're more like food. They don't have to approve themselves with the FDA. They're actually supposed to monitor themselves and tell the FDA if there's a problem. And so very frequently people get these things, find out there's a problem, report it to the adverse event reporting system, and go through this really convoluted pattern. There are 90,000 supplements manufactured in the US right now. You can imagine it's kind of hard to get through them. What about vitamin E? A lot of people take this. It's supposed to be an antioxidant, right? It is. But the DataTop trial in the 1990s showed that it is not helpful at all in slowing down Parkinson's, and it does not improve motor symptoms at all. It didn't improve any symptoms. And that was a good, well-designed, federally funded NIH trial. And meta-analyses of people taking vitamin D back in 2005, looking at 136,000 people in various studies, showed that the use of vitamin E at 400 international units might increase all causes of death, not decrease. They didn't find any decreases. They didn't find any improvements. Taking big doses of vitamin E is actually dangerous, and this happens all the time. People come in taking it. I'm not sure where they're getting that advice. There is NET-PD, which is National Institutes of Neurologic Disorders and Stroke, exploratory trials in Parkinson's disease. And this institution studies these molecules to try and figure out what does slow down Parkinson's disease. And they've done several trials over the past many years. This was one on creatine. I still have a lot of people coming in taking this. Bottom line, 45 sites in the US and Canada with 1,700 people, no benefit whatsoever. Don't waste your money. CoQ10. I can't think of a single illness for which people aren't told to take CoQ10. My wife had a problem with her gums and was advised to take CoQ10. And there is a lot of really interesting data. It works in the mitochondria, the power factories of cells. In test tubes, it seems to protect neurons. But in people, it doesn't. Unfortunately, there was a really large multi-center trial done at academic institutions that found futility. It did not slow down disease. It didn't improve disease. And it's really expensive. About 5 years ago, I polled a bunch of patients to see how much they were spending on CoQ10 each month, and it was between $60 and $80. It just doesn't help. What about plant-based stuff? I don't see Kava very often. We used to see it more. When I was a fellow, several people came in taking Kava. There's some data that it might improve dopamine levels in the brain, but it's just too dangerous. It's a plant, a pepper plant. But it doesn't improve Parkinson's. There are studies showing it does not improve motor symptoms. And in fact, it's dangerous. If you mix it with alprazolam, which is Xanax, some people have been reported to have a coma-like state as a reaction. And there are numerous reports of liver injury. I stuck a few of them at the bottom of the screen there. Those are just references to articles. Mucuna pruriens. This is a really interesting one. Before I moved to Maine, I'd never even heard of Ayurvedic medicine. And Ayurvedic medicine dates back thousands of years in India. And if you look at their literature, they've described Parkinson's disease for at least a couple thousand years. And they've treated with this Mucuna pruriens. It's the velvet bean. And it does contain levodopa. There are precious few good studies looking at what the content of that levodopa is. There was one really good one I referenced down at the bottom here in 2004. And they actually showed that compared with standard carbidopa, levodopa, there was no significant difference in dyskinesia or tolerability. Patients probably did a little bit better, actually, in the study, but it was a really limited study. Everybody got one dose. And they were randomized, so they didn't know which of 3 different compounds they were getting. But in the immediate several hours after that one dose, people did better. The authors of this study called for other studies, but I haven't seen a lot. There are a few things out there. It looks promising. It does look promising, and I'd like to see more from it, but I've not encountered a good supply. I haven't found a good way to take this. It's not standardized, and it's really important to target the amount of levodopa that you take. So if that data were to become available, that would be a good thing to consider. But I think we really need more trials looking at this. But I included this because I'm really fascinated by it. I think it's an interesting natural source of levodopa. However, it is a type, it's used in Ayurvedic medicine. And as I said, before I came to Maine, I'd never even heard of this. Nobody ever came to me at Baylor and said, I also take Ayurvedic medicines. But they do here. Not the majority of you, but it happens. Every so often someone will come in, they're taking this stuff. And there are numerous articles about dangers with Ayurvedic supplements. This was in 2000 to 2003. This is the Center for Disease Control. I just did a little screenshot. They're reporting lead toxicity, arsenic, and mercury in 5 states during those 4 years just from these supplements. They're not in every supplement, but what they tell you here is that with this ancient practice, they thought that mixing minerals, herbs, and plants together would provide an added benefit, and I can't really go into all the details of how that works, but in some cases it's thought that these toxins, lead, mercury, and arsenic are actually intentionally added. In some cases, it's a byproduct of choosing bad soil. But I can tell you now, there are no good, safe doses of lead, mercury, or arsenic. Don't take them. Don't take them. And most of the time, it's not on the label. But every now and then, I've seen one that actually says lead as an ingredient on the label. Just don't do that. So in Boston in 2004, investigators went around to shops that sell these things and collected a bunch of them, and they found that about 20% of them contained potentially harmful levels of lead, mercury, and arsenic. You know, the verbiage changes a lot with this stuff because there are guidelines about how much lead can be in your water and all of that, and as you probably all know, we have a real problem with lead water mains in this country. But it's more like the guidelines meet the problem instead of the science. There should be no lead. This is from the Houston Department of Health and Human Services in 2006. They went around to a bunch of local shops, bought a bunch of stuff, and found at least 7 manufacturers of Ayurvedic medicines were consistently adding lead and mercury to traditional South Asian remedies. This is a later study, 2008. What these guys did, this was the same group that did the shopping around in Boston. What they did was they went online, they used 5 different search engines like Google and stuff. I forget which ones they used exactly, but they used 5 different search engines. They found 25 companies that offered these Ayurvedic supplements, and they randomly picked 230 of them and purchased them, or they put in the credit card number and 193 of them showed up, which is kind of a funny little statistic by itself, right? So of the 193, they received and analyzed them, and they found that in the U.S. manufactured products, 21.7% of them contained these toxins I'm talking about. In the Asian manufactured, about 20%. 95% of the metal-contaminated products were sold by U.S. websites. And so people see these websites and think, oh, that's in the U.S., it's reputable. But 95% of the ones with the toxins were from the U.S. 75% of them claimed this good manufacturing practice. This is what the FDA tells them. You have to use good manufacturing practices. And it's this legal term in reference to how these things are manufactured. And you can claim it. It doesn't mean that they'll ever get around to your factory and check on you, mostly because they're limited in scope when it comes to these things. This is Canada. It's not just us. The Healthy Canadian government posted this warning that these types of Ayurvedic medicinal products may contain very high levels of heavy metals. They're dangerous. And this is last year, the state of New York. They found elevated levels of arsenic, lead, and mercury in 20 samples. They just went around and randomly bought them. I just put this last one up, and I'm beating it to death because that's last year. This is not over. It's still going on. The Iowa Department of Public Health did this really interesting survey. They said, if you use these things, will you come in and just let us check your blood levels? So 115 people who used them came in, and 40% of them had elevated levels of 10 or milligrams per deciliter, which is too high. 9.6 had levels of 50. And a lot of them donated the samples of their supplements, so they got 182 distinct supplements to test. 27.5% of them contained toxic amounts of lead. If you type in supplements and liver toxicity, you will find many, many articles in PubMed. This is just one little shot of some of them. So lastly, people will come to me and they'll say, but I got it from Dr. So-and-so, I bought it in their office. This must be safe. The American Medical Association actually has a statement about this in their Code of Conduct. And I'm just going to read this out loud. Sales of health-related products by physicians raises ethical concerns about financial conflict of interest, undue pressure on the patient, erosion of trust, undermining the primary obligation of physicians to serve the interest of their patients before their own, and demeaning the profession of medicine. The Maine Board of Licensure reflects this language. They quote it. And so if you're like me and you're up to recertify, you have to answer questions about this. So I thought I'd end on a positive note, since most of that last section sounds so negative. And frankly, about once every few days when I have this sort of talk with the patient, they get very upset with me because for some reason people are really emotionally attached to supplements. I want you to know that supplements and other molecules are being investigated. There are a lot of trials looking at these things by academic institutions. And if you just go on clinicaltrials.gov and you have a supplement of interest, you can type it in and see if there's a trial going on. There may be very good data. Like Mucuna pruriens, there may be something out there that is really helpful. But this is just a list. I don't want to read through these, but even things like caffeine are being studied. Calcium channel blockers. Nilotinib, many of you probably heard about that. Georgetown's running a study right now. Very interesting. And I talked in April this year about vaccines. They're still under trial. There's a lot of good work going on. And we're talking about vaccines for people who already have disease, not people who want to prevent it. So there's a lot of really interesting stuff going on. A lot of compounds are being investigated. So I think I'll stop there. Questions?
How about wine?
How about wine? I don't know of any data to support wine. It sounds good. Do you know of something?
Not yet.
Not yet? What was your question, ma'am?
Would you say a few words about whether or not eating meat is a great idea or not?
Well, I think from the standpoint of human biology, it's probably not good to eat nearly as much as Americans do generally. Meat should be treated like a smaller portion than these giant porterhouse steaks and stuff that people eat in general. It's hard for us to digest meat. Red meat can sit around in the colon for up to 2 weeks in some people. And people with Parkinson's disease have slow transit, meaning the movement of stool and other things becoming stool in the colon is slowed down, which is what causes the constipation. And it's this self-perpetuating cycle where if it slows down, it also dries out. And if it dries out, it slows down. And that's a problem. Red meat already taking longer, things like red meat and cheeses that take a long time to get through the colon can really constipate people. And if you take a lot of things containing high amounts of protein like red meats at the same time as carbidopa, levodopa, you may not absorb the levodopa, which is the active molecule. They compete. They have to go through the same channels. I imagine it like a bunch of people at the queue just trying to get on the subway before it leaves. Not that we have any of those around here, but they're just trying to get through and they can't. And because transit's happening, the Sinemet may just go on downstream and you never absorb it. And the same thing happens at the brain. The brain is protected by the blood-brain barrier. And those same sorts of channels are there. And if you've just eaten a cheeseburger and taken a Sinemet, they arrive at those gates and want to both get through and they may compete. And so that can be a problem. But in terms of whether or not red meat improves anything, I don't know of any data for or against red meat in Parkinson's disease. There's no data for this eating for your blood type or anything like that. But a lot of people ask about diet. And I don't want to give the message either that people shouldn't eat protein. You should definitely eat protein. A lot of people try to put the protein at the end of the day, for example, or they just follow the rule of taking their pills 1 hour before or 2 hours after meals containing protein. So 1 hour before, 2 hours after. And that works. But I would try to work the diet around the pills instead of the other way. Yes, ma'am.
What about turmeric?
Turmeric, there's some limited data there. What about turmeric? This is curcumin. There's some limited data there. There's not any guideline. There's not any solid scientific support yet, but there is some limited data. It might actually be very helpful. And it might be involved in the formation of Lewy bodies, which I didn't get into, but if you look at the brains of people with Parkinson's disease, the pathologic hallmark is this collection of proteins called a Lewy body. And the Lewy body is made mostly of alpha-synuclein, and turmeric is thought to help prevent the alpha-synuclein from getting into the wrong shape and winding up in the Lewy body. But it's still under investigation. And this is the leap that a lot of people wind up taking. They hear that there's some basic science for something and they want to try it, but it's not FDA approved yet. And it might be available in the grocery store. And so they go get it. And I can't fault you for that, but it might not be safe either. And so we don't know yet. That's why we do these big trials. We figure out, the safety, and then we figure out the efficacy. Yes, ma'am.
So curried meat then would be a good thing. Ted, that's
Hold on just a second.
that's
I didn't say that.
American. I know.
I didn't say that.
My question is, Ted received this, and I wondered if in your spare time you would look that over and tell me if it's garbage or if it's
Oh, yeah.
real.
So is curried meat a good idea? No, I'm not saying that. It might be in the future, but it might be right now, but we just don't have the data. I love curry, so I really do.
Full of American, human, and all the rest of it.
Yeah, but they get Parkinson's at the same rate that
Well,
we do.
that's
So
true.
the people who make the curry, and eat the most of it. It sounded a little weird. Yeah. So the question is this appropriate? This is a brochure for Duopa. This is the U.S. FDA-approved version of the dopamine pump. I mentioned a moment ago in Europe that for several years they've had something called duodopa, which is a dopamine pump. This is what we have approved in the U.S. Very similar. It's a good thing for people who need it. It's a really potent thing. It's an external pump that one might wear in a shoulder holster, like on the old detective shows where they have the little gun right there. I worked guns into the conversation. But it's a little 1 pound pump. and it holds a cartridge full of liquid levodopa, and the problem that most people find untenable is there's a little peg tube sticking out right here, the hose sticking out of the front of you, and I think once most people see that, they think, oh, I don't want that. But if you have really advanced disease and deep brain stimulation is not the way to go, for whatever reason, the pump looks really effective. There were several trial sites around the country. I talked with Jim Boyd over at University of Vermont about how their studies went and how patients were doing now, and most of them, I hear, were doing quite well. And I have plans to probably use the pump in the near future. I have a couple of patients who are potential candidates, so we're working out all the kinks there. Other questions? Sinemet?
I have two questions. So the exercise thing sounds like it's intensity versus anything in particular. So that's question number one.
Mm-hmm.
And question number two is, what are your thoughts on low dose naltrexone?
Okay. So exercise first. Intensity seems to be a common denominator in most of those studies. If you push the heart rate up in particular, this is where we start to see people do better. And there were studies, for example, the one I showed with the just 8 patients at the beginning, they actually looked at beta CIT scans, which are like the modern DAT scan, to look at dopamine transport, and they showed that that people who exercised more had better dopamine transport, which is really interesting. And there are multiple studies showing that, although all different kinds of exercise have their own benefits. And so weight bearing can be helpful, core strength can be very helpful. They just help different things. But if you want to improve the motor function, the rigidity, the stiffness, and the tremor, then it's the high-cadence cycling, it's the heartbeat, it's a faster heartbeat that seems to be the common denominator. So what about naltrexone? That's an interesting drug. So most people know it as a drug you can use if someone overdoses with opioids. It can block the opioid receptors. It's the drug that people keep talking about cops carrying to save people who have overdosed. And there are a bunch of different studies looking at it as a mechanism to curb other types of cravings like alcohol. It's pretty effective for that, I've read in small studies. But I've not seen a lot of data in Parkinson's. Is there something in particular you saw?
I've read a couple of books
Mm-hmm.
that talked about slowing the symptoms down dramatically.
Mm-hmm. What were the books?
I can show you them.
Okay,
I have
so
them
maybe
online.
after.
I can show you them online.
Okay.
The good friend's dad has it, and
Mhm.
he's a doctor, and he put his dad on it as soon as he was diagnosed, and he said the symptoms haven't progressed in 10 years.
That's interesting. So there you have what we'd call in the academic parlance an N of 1. You have a study with one person. Yeah. Well, I mean, and it might be very powerful, but I haven't seen a trial yet, and there might be one. I'm not saying there isn't. I just haven't seen it. I do try to keep my nose to that grindstone and see what's going on, but I may be missing something.
It may be one of those drugs that have the side effects are minimal enough that it's worth a try.
It might be. It's an interesting molecule. Yes, sir. Yes, sir.
Hi, Laura, thank you for coming.
Thank you.
Number 2, 42 years ago, my wife and I and children moved on to Baraboo Drive,
Mm-hmm.
and our next door neighbor had Parkinson's, I had Parkinson's, and around the corner on Columbia, the gentleman had Parkinson's. Are we in a hot zone? Parkinson's?
Well, it's a good question. So the epidemiologist in you noticed something. I think most of us would wonder that sort of thing if we had a cluster. But I don't know of it being a hot zone. I mean, if you look at epidemiology studies, there are certain things that stand out, like exposure to rotenone, the pesticide, rural living, well water. If you grew up drinking well water, that might increase your risk. If you grew up working in a dry cleaner or a print shop where you use trichloroethylene, maybe not grew up, but if earlier in your life you were exposed to trichloroethylene or TCEs, these are all associations. And so what epidemiologists have done is they've asked people really extensive questions trying to figure out what were your exposures early in life. And those are the things that stand out. But do I have a bunch of other patients from the same area? No. I wish I knew more about what you might be exposed to. And if there was one, or if it's just random, 1% of people over age 60 will have Parkinson's, 4% over age 80. And Maine's a graying population, so we have a lot of people with Parkinson's. I keep seeing this statistic, by the way, when I look on websites and in newspapers, that there are 7,000 people with Parkinson's in Maine. But if you just look at the U.S. Census Data Bureau and just run those numbers I just quoted, elderly Mainers should represent about 3,500 people with Parkinson's. And then when you get to younger onset, like Michael J. Fox is a young onset Parkinson's, which is Parkinson's before age 40, it's really not common. And so there is a little bit of a gap in between there, between those two ages, but they don't represent another 3,000 or 4,000 patients. Yes, sir?
I also wonder, is there any relationship between Parkinson's and medications and cancer?
About medications causing cancer?
Yeah.
Well, the only relationship I know of Parkinson's meds with cancer is melanoma. And I wrote an article about that. If you visit the website of Maine PD News. If you go to that website and just type in melanoma, you can read the article where I summarize all that data. In Parkinson's people, in general, the risk of melanoma is about double the general population, but that's still only about 1.5%. And do the medications cause that? The jury's really out on that. We don't know. Probably not. Yes, sir?
Oh, yes.
I'm sorry, I keep ignoring you.
No, yes. Different kind of question.
Yep.
You can see I'm kind of moved by it. When you diagnosed me with Parkinson's 3
Mhm.
years ago, I took it as a death sentence. I've,
Okay.
tried everything and nothing worked. I keep coming back to you. But a couple of, and the big concern for me was when I got the tremor, but was apathy and depression. I mean, it's just like, what's life going to be like from here? And a couple of months ago, I took a book out of the Brunswick Library called Breaking the Habit of Being Yourself. And it essentially is about the power of positive thinking, but sincere positive thinking. If you really have positive thoughts, then you have positive feelings, and that affects your health a lot. And so I've been doing this meditation, and my attitude is really good now. It doesn't help the tremor, but I wondered if you could speak to depression, apathy, and not talk about drugs and ways to damp it down.
Sure.
Yeah.
Yeah, so depression and apathy are usually late findings in disease, but some people get them early. There are a sizable number of people I've met over the years who have told me their first symptom was some sort of mood problem. And so it's the opposite of what we expect. And there are medications that sometimes help, but I agree, if you want to try and find some sort of solution, it may take more than one approach, and meds might be part of it. Some of these studies, I didn't really go into this, some of the studies on exercise showed that quality of life measures, that global depression scores and anxiety scores, as measured by psychologists and psychiatrists, actually do improve with regular exercise. I think there's very little other data. There is a lot of data about the power of positive thinking, but it's usually on the softer side of scientific journals. It's really hard to measure, It's really hard to measure. But I can tell you anecdotally that a lot of people tell me they feel better if they have some sort of revelatory experience or some sort of insight like you've had reading the book. I think sometimes people have to sort of place themselves in a different way of thinking, and sometimes that is helpful. But no, I don't know of any other way. I do find that exercise is probably the most potent thing I've found. Yes, sir.
Did I understand your presentation to indicate that you need to wait about a month on your drug changes?
So that was the comment I made about steady state. Do we have to
Right,
wait a
yeah,
month?
You said something about
Yeah.
28 days.
Yeah. So if you look at studies of how these drugs affect people, there's first an immediate effect, like you take a dose today, you feel something today, or you don't, depending on the size of the drug, or the size of the dose. But then if you just keep taking the medication, the neurons in your brain actually change. The density of receptors in the brain changes, and the tone of that response changes. So it's sort of like you're slowly adjusting the idle speed or something like that. And over time, the way that you respond to medication changes because the hardware of your brain, the actual proteins on the outside of those neurons change, and probably a lot of the function inside of the neuron changes, and that is what really makes all the difference. It just takes a long time. Neurons are funny little things. You know, they have cell bodies, but then the cell bodies have dendrites and axons that reach out. Just to veer off into why that happens a little bit, young adults have about, well, the number keeps changing. There are billions and billions of neurons, but each of those billions of neurons can form a maximum of 10,000 connections with other neurons. And so sometimes the axons are really long, and they contain these protein tracks on the inside of them. And if a neuron wants to change how it functions with another, it has to actually use those tubules inside of the axon to send a protein out, and that's the rate-limiting step. It takes time for neurons to do that. And so it can take up to 28 days before it's changed the whole configuration. Yes, sir?
When you put all of the tests, all of the trials, everything you've said today in a bucket,
Mm-hmm.
are we treading water or making progress?
That's a great question. So when we put all the trials that we've talked about today in a bucket, are we treading water or making progress? We're making progress. We're making really big progress. The thing I mentioned at the end about vaccine trials, I'm really excited about that. There are growth factor trials that are really interesting. The stem cell trials look really positive these days. But we know so much more about how this happens, how this works, and how people respond, and why earlier trials failed now than we used to. I went to the Movement Disorders International meeting in June, which was in Berlin this year, and there were thousands of presentations and abstracts about basic science. There were too many to see them all. And there were also formal presentations by well-regarded speakers with a great track record, and some by people who were just new but had interesting things to say. It was a fantastic meeting. There was so much to see there, no one could possibly see it all. And that's true, too, with the literature. I often tell people, anything I say I've probably actually looked into because I'm that eccentric, but I get 10 pounds of journals a week. And yeah, it's funny, you know, that's an average. So I measured for a couple of months, how many pounds of journals do I get? And I read a lot of it. I'll never read all of it. It's too hard to do that. Nobody has enough time in the day. And so what I and most of my friends in movement disorders do is first we look at the table of contents, and then we look at abstracts, and then we read articles that are interesting. And then the problem is that one article may lead you to 7 other interesting articles that are not in the 10 pounds of journals. And so you've got to have a really, really avid interest in this stuff to keep up. But the bottom line is we're making a lot of progress. We really are. I think this vaccine thing is going to be very interesting in the next couple of years. I don't want to put all my eggs in one basket with that, but that's really fascinating. Yes, ma'am.
In terms of exercise, I've heard about a bike advertised specifically for PD called TheraCycle.
Right.
I'm just curious if you have any experience or knowledge about that.
Do you want to speak to that? Yeah, there was at least one trial where they used TheraCycle, and do I have experience with that specific bike? No, but there was at least one trial that looked fairly positive, but it wasn't with a high number of patients. I've had several people tell me they have them. I think when you were looking into yours, I looked into it a little bit more. but I've had several people tell me they have them, but I don't think anyone else in this room is one of those people. But they look interesting.
Where do you
Yes,
buy
ma'am.
them? Where do you see them?
I wouldn't know. The internet. In all caps. Yes, ma'am. Oh, really?
I pronounce it right, but this is a drug used with a Sinemet for my sister,
Mhm.
entacapone.
Entacapone, Comtan.
And I'm wondering, she's taking it in conjunction with the Sinemet every time throughout the day. I'm not familiar with it. What's your recommendations on combining the two?
Right.
A fairly frequent amount throughout the day.
So,
That's number one.
mhm.
Is there a dosage of that and the Sinemet that is considered high or low?
okay. So what do I recommend with entacapone, which is Comtan plus Sinemet, and is there a dosage that is high or low? Let's start with the second part first. So this is such a highly unique disease that we have to deal with the individual therapeutic window, to use some pharmacology terminology. So that's a moving target. How much someone needs and how frequently they dose what they need are moving targets that change with the person and with their disease. And so there isn't really a good single high-low dose. I think the FDA limits entacapone. They say that you should probably stop at, I want to say 6 doses a day. I don't usually go beyond that. It's either 5 or 6 doses a day. It's only a one-size pill, 200 milligrams. I don't usually find it helpful beyond that. I do have a few patients who take more.
She takes a half a pill 8 times.
Half a Sinemet or half an entacapone? Entacapone, yeah. Well, that's probably reasonable. It's not really scored, so it's not easy to break those to take a half. But
It's not too much then.
no. But should they be mixed together? They sure can be. The big trial was called the STRIDE study, just like it sounds, where they compared people with and without entacapone and carbidopa, levodopa, and they showed very positive results. People got close to 2 hours more on time. On is when your medications are working. Off is when they're not. And they got less off time. And the on and off time were almost the same. I would think that they would be exactly the same, but the difference, I mean, in them. Sure. Yes, ma'am.
You talked about the early signs and symptoms of Parkinson's.
Mm-hmm.
From what I've read, the tremors usually start distally in the hands.
Mm-hmm.
Is that always the case, or is there a certain progression?
Sure. Do tremors always start in the hands? No. The most common place is in one hand or the other. It's unusual to start in both hands, but that does happen a small percentage of the time. The head does happen sometimes. It's much more likely that a head tremor is essential tremor, especially if it's a presenting tremor, but I've seen plenty of people with Parkinson's have a head tremor also. The foot can be a location of tremor, any limb. And sometimes people experience tremors years before that they feel on the inside, more of a global kind of shakiness that no one else can see. And they'll tell me that that was where it started. Yes, ma'am?
Have you ever experienced anyone in your practice that got anti-nausea medications as part of a cancer treatment and it showed up as Parkinson's-like syndrome?
So have I ever seen anyone take anti-nausea medications that show up as a Parkinson's symptom? And specifically you mentioned for cancer. Yes. And the reason is that a lot of anti-nausea medications block dopamine receptors in the brain. For instance, Reglan, metoclopramide, is a really effective drug for that. There are 5 known dopamine receptors in the brain. It blocks all of them. And you can take Reglan all by itself for no reason at all and look just like you have Parkinson's disease, just from taking Reglan. And there is sort of a descending hierarchy of those drugs. Zofran, ondansetron, does not bind to dopamine receptors at normal or smaller doses, and it is probably safer. Some people go to Canada to get a drug called domperidone, which also works on a different system than dopamine and is safe in Parkinson's. It's used the world over, but it's never been FDA approved for anything. although movement disorder doctors in the US and gastroenterologists recommend it all the time. Others? Yes?
If somebody is having hand tremors, how long would it take before Parkinson's develops?
Well, I would argue that if they're at the point of having the tremor, they probably have Parkinson's then. But it's a complicated thing. The diagnostic criteria are that you have at least 2 of the motor symptoms. So you'd have slowness and tremor. So slowness is the single most important symptom. 1/3 of people don't ever have tremor. Or if they have tremor, it's really minor. But the slowness of movement, the so-called bradykinesia, is the most important finding. If they have tremor, then they've lost 60 to 70% of dopamine on that side, and it's taken them 6 or 7 years to get to that point. So I would argue from a physiology standpoint, they've had Parkinson's for quite a while. They just don't know it. The Nupro patch? So the Nupro patch is a dopamine agonist. It's like Mirapex and Requip, but it's in a patch. And it lasts for 24 hours. It binds to dopamine receptors in the brain. It helps symptoms like stiffness, slowness, tremor. And it does not improve gait. It has all the same side effects that I listed before: the sleepiness, foot swelling, sleep attacks, impulse control disorders. But you've got to remember, when doctors talk about side effects, most of the time the side effects are not that frequent. And so the majority of people don't have the side effects. But most drugs with Parkinson's are tailored to improve symptoms and avoid those things. How are we doing on time? We've probably gone past what we expected. I'll be happy to stand here and answer any more questions, but we should probably let other people go. I appreciate your patience. Thanks for having me.